this. You give the answer, he will give you 500 real. Put burden on others. Or if you don't want him, he might give you. He is a wealthy man here. It is called Saturday night palsy. Saturday night palsy. There is a nerve, the nerve is damaged. So hand is gone. Okay, Bismillahirrahmanirrahim. So the complement deficiency diseases, we discussed complement system. What is complement system? It is the additional system that helps the defense mechanism. Tamam? And it is made up of 20 proteins, 20 plasma, 20 or more than 20 plasma proteins, and produced by the hepatocytes mainly. Tamam? Monocytes, epithelial cell, GI tract. Constitute 5% of the weight of the serum globulin factors, and majority of them, they behave like proenzymes, where one is activated by other and another is activated by other, and there are so in this way they activate themselves. 4 major mechanisms. We know the pathways: classical pathway, alternative pathway, and ambilectin pathway. The early components of the pathways are same. However, the early components of the pathways are different. However, the late steps are same. Tamam? For classical pathway, you need antigen antibody complex, while for others you don't need antigen antibody complex. Clear? What are the functions? 4 major functions. 4 major functions. Lysis, killing. Number 2, opsonization, activation of the inflammatory process, and last but not the least, immune clearance. So 4 major functions: lysis, if you go like this, lysis, opsonization, triggering of the inflammatory process, and last but not the least, the immune system. Now, classical pathway, ambilectin pathway, alternative pathway. Now, just imagine if there is a deficiency of one or more component of the complement system. Directly or indirectly, 4 mechanisms of the immune or defense system will be jeopardized. 4 mechanisms will be jeopardized: lysis, opsonization, inflammation, and immune clearance. 4 will be jeopardized. Tamam? Just imagine in your mind that if these 4 systems are not there, what can happen to the body? We just saw the host parasite relationship. When the immune system is decreased, flora present in the nose, flora present in the throat, flora present on the skin, microorganism present in the gut, in the kidneys, so everywhere we might have high chances of the diseases. So, complement deficiency diseases, we say that the components, just see first the 4 major things. The component of the activation pathway, if they have the problem, C1q, C1r, C1s, ambilectin pathway, then factor B, factor D, and then from C5 to C9 the MAC. Control proteins, soluble protein and membrane protein. Soluble protein, C1 inhibitor, factor H, factor I, S protein, binding proteins. Membrane protein, DAF, decay accelerating factor, CD55. Mucopolysaccharides, mucopolysaccharide, CD46, CD59, and then HRFs. We discussed this earlier in detail. Receptor problem. We know that there are receptors: C1 receptor, CR2 receptor, CR3 receptors. Then acquired deficiencies. So deficiencies can occur in the components, deficiency can occur in the protein system, deficiency can occur in the receptor, problem can occur in the receptor, or there may be some acquired problem. Okay, now we will go them one by one and then we will quickly give you an idea. Now, if there is a problem of some complement deficiencies, how you would judge that there is a complement deficiency problem, or there is an immune deficiency? For example, increased susceptibility to these infections. bacteremia and meningitis, staph pneumoniae, staph pyogenes, H. influenza, Neisseria, autoimmune disorders, arthritis, skin problem, tamam, and angioedema. We discussed this in the first PBL, angioedema. So if you see somebody with these features, one of the research said that if you found somebody to have that gentleman took antibiotics twice in 3 months, 2 times in 3 months, just imagine there is something wrong. Tamam? If somebody came to you, oh, I was having problem and then I took antibiotic, okay, tamam. Then what happened? Then I have another problem, then I took, but that was 1 month back. He is saying like this, you understand? And your brain is moving toward the other side, that why, how come this gentleman having antibiotic in 3 months, twice in 3 months, twice in 3 months, tamam? Or if there is an autoimmune problem, or if there is an angioedema, so then you can think for that there must be something problematic. Now, how to test? First we discussed the complement system, we discussed the pathway, we discussed the 4 mechanism, that what can be the 4 mechanism where the problem can occur. Then we saw that how we can judge that there is a problem in the complement system. We covered the 3 components, tamam? How we will test that there is a problem in the complement system. So there are different mechanisms to test the complement system. One is CH50, another is AH50, another is the level of 3 and 4, C3 and C4 level, and then some other test, C5A, C3A, C3B, BB, these are the tests. Now what is CH50, what is AH50? Very simple. CH50 is a screening tool to detect the deficiency of the classical pathway, and this test assess the ability to lyse the serum, sheep erythrocyte, which is, now I will give you a simple to summarize it. We took sheep, khuruf, tamam? We take the RBC of the khuruf. What we take? RBC of the khuruf. We take rabbit. What is rabbit? Huh? Huh?
In Arabic.
Huh? Huh? Arnab. We take arnab. We take the antibodies from that. Antibodies from that, RBC from sheep. We add antibody, so this RBC is for this antibody is what? Antigen? Right or not? This is khuruf, this is rabbit. We add them. Now antigen and antibody complex. Antigen antibody, tamam? We take serum, for example my blood. I took the blood, 110 ml, we made a serum for this, or plasma, tamam? Plasma. We take plasma. You know the difference between serum and plasma, huh? Serum after the clotting, plasma without clotting. Serum without anticoagulant, plasma with the anticoagulant, tamam? So we take the plasma. We took this RBC with the antibody, RBC of the khuruf and antibody of the arnab, tamam? We put it here. If it is hydrolyzed 50%, ability to test the serum, erythrocyte, and then 50% within the due time, we say that complement system is working good. If it is less than that, we say the complement system is not working good. Clear? This is called CH50. AH50, C for complement, huh? H for hemolysis. What is AH50? It see the CH50 look which pathway? CH, classical pathway, antigen antibody complex. For alternative pathway, you don't need antigen antibody complex, tamam? So here, you don't need arnab, tamam? You don't need arnab, khalli with that. You just take the sheep RBC. Took the sheep RBC, put it into the serum. If they are 50% hydrolyzed, 50% hemolyzed, you say that there is a okay. If it is less than that, you say that there is a problem. Clear? So this is called CH50, AH50. I will give you the example of this. And then measurement of the C3, C4 level and some other test. Now this is CH50. Serum complement hemolytic activity. Serum complement hemolytic activity. CH50, classical pathway, for the classical pathway. Serum complement hemolytic activity. Serum dilution at which 50% of the hemolysis occur. If 50% of the hemolysis occur, fine enough. If less than 50%, there is a complement deficiency. There is a problem. Tamam? 1 unit of CH50 defined as the volume or dilution of the serum that lies 50% of the erythrocyte in the reaction mixture in the given time. So you say within 1 hour, if we put 100 RBCs and this serum is having a complement system, classical pathway is working. So how many RBC will lyse? 50%. 50 RBC should be lysed. If it lies 50 RBC, fine enough. The complement system is Mia bil Mia. But if it is not lysing 50% of the RBC, it means there is something wrong. Clear? So here CH50 is a screening assay for the activation of the classical complement pathway, and it is sensitive to the reduction, absence or inactivity of any of the component pathway. The CH50 tests the functional capacity of the serum complement and the classical pathway to lyse the sheep red blood cells pre-coated with Arnab anti-sheep red blood cells antibody. Tamam? When this combination SRBC, sheep red blood cells, tamam, when this combination pre-coated with the antibody, Arnab antibody, when this combination incubate with the serum, test serum which you want to test, my serum, your serum, and if the pathway is activated, there will be a reduction, there will be a hemolysis. If the complement is absent, complement system is weak or absent, the CH50 level will be 0. If one or more component of the classical pathways are decreased or deficient, then the CH50 will be decreased. Now, what are the complement component deficiencies? Deficiencies of the complement system are rare, but whenever they are, it leads to problem in the defense mechanism and increased susceptibility to what? Come here. Yes, come here. You, not you. Yes. Increased susceptibility to what?
Deficiency.
Huh? A deficiency will lead to susceptibility to what? That's why I am asking, come here. Susceptibility to infection. Susceptibility to infection. Sit down here in front of me. No problem. You just have your lunch, but sit down here. Now, so this is one. This is one problem. One problem, what will be the first problem? Increased susceptibility to infection. What can be the other problem? What are the 4 functions? What is the last function? Immune clearance. Immune maafi clearer. When the immune complex is not cleared, immune complex is made up of what? Antigen and antibody. When this antigen and antibody is circulating in the body, and wherever it reaches, it will cause what? It will cause inflammation. Understand about it? When there is called inflammation, it creates problem. Clear? So it will lead to joints, create arthritis. It will lead to kidney, damage the kidney. It will lead to skin, create the problems. You understand about it? So this will be the problem. Third, angioedema. And some of the instance, the patient sometime they don't have any problem, asymptomatic. Okay. How we classify the inherited classical deficiencies? We have inherited classical pathway deficiency, inherited ambilected pathway deficiencies, inherited alternative pathway deficiencies. We have C3 and late component deficiencies. Some inherited deficiencies, inhibitor proteins, complement inhibitor proteins. Some of them they are autosomal recessive, many of them they are autosomal recessive. Few of them they are autosomal dominant, for example C1 inhibitor deficiency, and some of them they are X-linked, for example propyridine deficiency. Propyridine, which pathway we discussed propyridine? Propyridine, which pathway? Commonly autosomal recessive, that's why they are not so common. Autosomal recessive, autosome recessive. For the disease there must be 2 gene defect. Tamam? If one gene is defective, one gene is normal, the function will be there. The function will be there. Autosomal dominant C1 inhibitor, C1 inhibitor. So autosomal dominant C1 inhibitor. X-link propyridine deficiency. Which pathway? Alternative pathway? Factor D, factor B, propyridine, tamam? And some acquired deficiency. Acquired deficiency is when too much utilization of the complement protein, or there is a problem in the complement are synthesized where? Complement protein are synthesized where? In the liver. If there is a problem in the liver, liver cannot synthesize protein, the complement system will be there? No. So there is no problem in the complement system, but rather the problem is in the factory, in the liver. So this is called some secondary or acquired deficiencies. Okay guys, so these are the pathways, factor D, factor P, and then MBL lectin pathway, an alternative pathway, and then last common. Now why the defect in the early component of the classical pathway do not lead to overwhelming infection? Nah, because we have alternative pathways. Alternative pathways. Deficiency of the early components are poor, complement result in the poor clearance, immune complex resulting in increased immune complex diseases. Now, so we discussed complement, pathways, problems, and what are the signs and symptoms, what type of the infection can be there, what are the components they are deficient, how to test. Tamam? These are the things. Now the diseases. Inherited classical type 1 pathway deficiency, C1q, C1r, C1s, C4 and C2. If these are deficient, so what will happen? There will be impaired solubilization of the immune complex. Poor, see, listen, this is deficient, C1q and C1r. C1q joint, C1q, how many C1q are there? Come on, 6 are there, and they bind with how many antibodies? One time. Yes, come on. 2 antibodies, IgG, immunoglobulin G, tamam. So if they are not there, if it is deficient, C1q is deficient, it will bind with the immune antibodies? There will be a problem, isn't it? Antigen antibody complex will not be there, there will be a problem, it will not clear them. So what will happen? Impaired solubilization of the immune complex, poor immune regulation, and it will lead to a disease that is called autoimmune disease, SLE, systemic lupus erythematosus, with the severe infections. And these are the infections, if you match this slide with the previous lecture, you will find many of them there. You will find many of them in the saliva, many of them in the lungs, many of them in the GI tract. Tamam? So you will say, oh my God, these are there, they are normal, and then now they are creating problems. So infection encapsulated, and we discussed the capsule. What is the role of the capsule? To prevent from damaging, isn't it? So we said that, oh, these are the encapsulated organisms and they create problem here. So these can be the skin problems. You can see these skin problems. Tamam? Encapsulated organisms create these type of the infection. SLE is a systemic lupus erythematosus, autoimmune disorder characterized by multi-system. When there is an antigen antibody complex and it is moving in the blood, it will move to which part of the body? Everywhere, all part of the body. It will go to the lungs, it will go to the bones, it will go to the muscle, it will go to the joints, it will go to the kidneys, everywhere. It will go to the skin because that is moving, isn't it? So it is a multi-system inflammation with the generation of autoantibodies, autoimmune reaction directed against a constituent of the cell DNA, and antibody response related to the B and T lymphocytes. So here every part of the body has an effect. And what is the disease? The problem is in the complement system. Which complement system? C1q is not functioning. Antigen antibody complex is not clearing. When antigen antibody complex is not clearing, is wandering everywhere and damaging all parts from the skin to the lungs, heart, kidney, muscles. Every part of the body is affected. Clear? And this is a typical picture of the skin manifestation. This is called butterfly rash. Butterfly rash. See here, stuff like a butterfly. Like a butterfly. Skin manifestation, butterfly rash. It looks like a butterfly, huh? So it is called a butterfly rash. Then discoid lupus, very damaging, more damaging, and leads to ulcers. And then involve the vessels, vasculitis. And when the vessels are involved, it leads to ischemia. And then you can see the fingers. And then it leads to damaging the joints, proximal joints. And the joints are flex. You know swan neck. So it calls swan neck deformity, like this. Swan neck deformity. And you will see the people like this. They have the hand like this. Swan neck deformity. Why it is like this? It is because that these antigen antibody complex are going everywhere. Now, particularly C1q deficiency, the similar like SLE symptom but little bit different, and involve all of these common rash, vasculitis, septicemia, and commonly meningitis. C2 deficiency, 10 to 30% of the people, much individual present with this like symptom, SLE like symptom, usually no infection because the C1q is there. No infection, but they are prone to recurrent pyogenic infection, particularly encapsulated bacteria. And why the encapsulated bacteria? Because encapsulated bacteria, they have capsule. So their damage, they protect themselves from the immune system. Like you have vasta, huh? Shabab driving have a vasta, and shurta mawjood hina. But because he has a vasta, so no problem. Go like this. So that's why it's encapsulated. Huh? So where is that encapsulated man? And sometimes the people they wear like this. Okay. You know, when the old days, the story of 15 years back, I was the chairman of the department. I was the head of the department. And those days the Bluetooth was very new. This Bluetooth. We didn't knew what is Bluetooth. Really. Even one of our friends, he is a professor in US, he came and he brought this flash drive, USB, and he gave it to me. That, doctor, please put it in the computer, so we want to see this presentation. I didn't knew what is this. It is 20 years back. I gave it to the secretary. That he said to me, Prof, what should I do with this? What is this? Then the professor, he is a professor of atherosclerosis in Johns Hopkins. Then he realized that, oh, I think they are not aware of this. He said, look, it is a flash drive. In those days, the whole memory, the hard disk, you know how much? 512 MB. The hard disk of a computer. 512 MB. This was the whole, and 512 MB. I remember the gentleman said to me, doctor, you cannot fill this hard drive in whole life. 512 MB, really. So we didn't knew these things. So I don't know from where I started this. So the gentleman was having this Bluetooth and encapsulated, yes. Like this gentleman is wearing a capsule. In exam, the gentleman was wearing cap. It was a cold season, and he was having Bluetooth. and he was talking to, I don't know, somebody, we didn't knew. Even I made a round. I said to him, how are you, how is everything, you are feeling too cold? He said, yes prof, too much cold, you know. We didn't knew that there is something mushkila. Afterwards, you know, after the exam finishes, one student came to me and he said, I want to talk to you. I said, yes. He said, look, this gentleman has a device in his ear. I said, how come? He said, yes, there is a device in his ear, small device, and he was talking to somebody. And then I called the gentleman, come here. I said to him, look, tell me the truth. I will not do anything. I don't harm the student. I love students, but tell me the truth. He said, yes. My Baba brought it from US and this, and then he showed me, oh my God. Encapsulated. Not in Pakistan. In Pakistan. He was a dental student. He might be a good dental surgeon now. So he was encapsulated, tamam, dodged the immune system. So these are very dangerous. That's why when we come to the class and we see this cap and all these things, we become very anxious. Wallahi, you know, you guys are very fortunate, because if you go back 40 years back, you would have not found these cars, these systems. You understand about? Even I hope many of you you don't know what is telegram, what is telegraph. Even now the postmen are not there. Even the home telephone, they are redundant now. Nobody gives home telephone. Our time was that when it used to take, it was a status symbol. Oh, my home, I have a phone telephone. Oh, you have a phone telephone? Now everybody, if there are 10 people in the home, there will be 20 mobiles. Trust me. Go home and count your people, how many people you are. And trust me, go home and count the mobile will be more than the people. If there are 10, 2 father, mother, and then the rest of the kids, you will see the mobile and tablets, they will be more than that. Count them. So technology is so fast. Okay. Second is the inherited MB-lectin pathway deficiency. MB-lectin pathway. So what happened? This is why we call first line defense. Why MB-lectin pathway is a first line defense, or alternative pathway is a first line defense? It is because that for classical pathway you need antigen and antibody. It is not like this that pathogen came, for example virus or bacteria came, and ala tul there will be antibody. It is not like this, isn't it? For example, if a dangerous person came here, or for example there is an accident, do you think that ambulance will be there all the time? It will take time, isn't it? 5 minutes, 10 minutes, 2 minutes, 3 minutes, isn't it? So similarly, so that's why antigen antibody complex take time to activate the classical pathway, or classical pathway to be activated. But in alternative pathway, in MB-lectin pathway, you don't need antigen antibody complex. Clear? So that's why we call it alternative first line of the defense. So when these pathways are defected, we say the impaired first line of the defense, and again repeated infections, very repeated infection, accelerated course of the SLE. If there is an SLE type of the disease, it will be fast, and rheumatoid arthritis. And inherited alternative pathway deficiencies, again immune complex will be problematic, first line defense with the microbial will be problematic, and again infection with the encapsulated organism, Neisserier's infection. C3 and C5 deficiencies, the lactate complex, and then it is very much important and can lead to severe infection and autoimmune disease, severe infection. C3 deficiencies, severe recurrent infections with encapsulated bacteria. Control proteins, now so this was the pathways problem. Control protein, C1 inhibitor, we discussed angioedema. Factor H and factor I, uncontrolled activation of the alternative pathway. And DAF and CD59, inability to inhibit C3 and C5 and MAT. And all these leads to problems. C1 inhibitor, hereditary angioedema. Factor H and factor I, pyogenic infection, secondary deficiency because of the glomerulonephritis. And flat acting problems, MAC deficiency, it can lead to a situation which is called paroxysmal nocturnal hemoglobinuria, PNH. What is this? I will let you know. Then the third component, third is the receptor deficiency, CR3 receptor deficiencies. And we discussed this earlier. You remember the receptor, CR1 receptor, CR2 receptor, CR3 receptor, where the complement system comes and attach with the phagocytic receptors, and then the phagocytis is activated. So there is a receptor deficiency. So when there is a receptor deficiency, again leukocyte adhesion will be defective, and then infection will be more and more. You remember this, huh? Or should I show it to you? Let me show it to you. This is complement one. We have discussed this. Now, شوف here. يلا show you the receptors. Aywa. See here receptor. You can see the receptor here. FC receptors, C3b receptors, and these receptor binds. But when these receptors are deficient, the complement system will not be activated. Clear? So this is the receptor. Okay. So here CR3 receptor deficiency. Tamam? Maybe CR1, maybe CR2, maybe CR3 receptors. Now acquired deficiencies, when there is accelerated consumption of the immune complexes, too much infection, repeated infection, or liver problem, reduced hepatic synthesis, or kidney problem, protein loss. So in all these we will be here. C4 deficiency is highly encoded with the polymorphic genes, and it leads to different types of the technically deficiency is there, but whenever there is a deficiency is predisposed to SLE. Now C1 inhibitor, we are not going to detail of the C1 because we discussed this in the PBL1, tamam. But there are two types, one is type 1, another is type 2. Type 1, 85% of the patient suffering from type 1, and here there is no detectable protein. And type 2, 15% of the people they are suffering, but there is a dysfunctional protein. So protein मौजूद, but it is dysfunctional. So this is the hereditary angioedema. And treatment, no specific treatment, or if you have, like, you can just treat the situation or give them the vaccine. Now CD59 deficiency, PNH, CD55 and CD59, the MAC deficiency, PNH. It is a misnomer. It's called paroxysmal nocturnal hemoglobinuria. They said that when in the night the blood become acidic, so the hemoglobin get lysed, attacked by the RBC, by the CD59, and then they lyse, and then the hemoglobin come in the urine. So that's called is paroxysmal, sudden, nocturnal night, hemoglobinuria, hemoglobin appear in the urine. But it can occur in any time. What happened? Their technicality is there. Very technical point. It's a very technical point in your leaving. The technical point is there is a GPI protein. GPI protein. This GPI protein is coded by a PIGA gene which is present on the X chromosomes. This PIGA gene give an instruction to the system to synthesize GPI protein. and this GPI protein is present on the RBCs. Tamam? So I will take you here in order to, this is the PIGA gene on the X chromosome. Which arm is this? P arm or Q arm? P arm or Q arm? P arm. So it is present on the PIGA gene, X chromosome PIGA. Tamam? Now this synthesize a protein. This protein is called PIGA protein, GPI protein. This is RBC cell membrane. Clear? This is GPI protein. What is the function of this GPI protein? This is complement system. Mushkila. Tamam? Complement system want to eat RBC. It want to damage the RBC all the time. When there is an RBC, this complement system, maghzoob. Yeah, you understand? They have fight with each other. Complement system, Hazdami, complement system want to kill red blood cells. But there is a GPI protein. The GPI protein don't allow the complement system to attach with the RBC. The complement system, the GPI protein don't allow the complement system to attach with the RBC. Tamam? This GPI protein is coded by which gene? PIGA gene. And PIGA gene is present where? On the X chromosome. When there is a problem, when there is a mutation, when there is a problem in that PIGA gene, it will not synthesize the GPI protein. When it will not synthesize the GPI protein, there will be a deficiency of the GPI protein. When there is a deficiency of the GPI protein, the complement system will attack the, and when it attack the RBC will rupture. Clear? This is called hemolysis. Tamam? This is usually earlier it said that it occur in the night, so that's why it's called paroxysmal nocturnal hemoglobinuria, but it can occur in any time. Is this clear? The PNH hypothesis. What is the hypothesis behind the PNH? Role of the CD55 and CD59. This is CD55 and this is CD59, the MAC. So assalamu alaikum. So here again you have a decay accelerating factor. This is DAF and this is anti-DAF. The same mechanism for the DAF as well. Decay accelerating factor. It wants to kill the RBC, but anti-DAF is there. Anti-DAF anchor the DAF. Whenever there is a problem and DAF is too much or anti-DAF is not there, it will create a problem. So this is paroxysmal nocturnal hemoglobinuria. This is a very good document. I gave this document to you last time as well. I don't know how many of you have studied this. How many of you have opened this document? Honestly. How many of you has opened this document? Except me. This is a very good document. See all the diseases that we discussed: rheumatic disease, susceptibility to infection, angioedema, some asymptomatics, C4 deficiency, C1q deficiency, C5 deficiency, C6 deficiency, SLE, all diseases are there. Just properdin deficiency, we discussed properdin, tamam? And this is X-link and C1 inhibitor deficiencies. So my suggestion is that go home, read it. It is not bad. It is a good article and it can help you. In order to summarize the whole situation, what we discussed the complement. What are complements? We discussed the 4 functions of the complement: lysis, opsonization, activation of the inflammation and immune clearance. We discussed the 3 pathways quickly. Then we discussed the complement deficiencies. We said complement activation pathway deficiencies, control protein deficiencies, where the soluble protein or the membrane protein, complement receptor deficiencies and acquired deficiencies. We discussed the complement system deficiencies, increased susceptibility, and then we say that how we will say that this patient is suffering from complement deficiencies. If there is an increased susceptibility to infection, if there are presentation with autoimmune disorder or angioedema, we will say that that man is suffering from complement deficiency. I gave you a rough idea that how we will say that immune system is crippled or immune system is weak. If a person comes to you and said that within 3 months he took 2 times antibiotics, then you say that there is something wrong. There is something wrong. Then how you will check? You have CH50, AH50, plasma levels, and then other tests, C3A, C5A test. CH50 is a 50% hemolysis of the Huruf with the Arnab. Huruf red blood cells sensitized with the Arnab antibodies. Tamam. In AH50, there is no need of this one, no need of this one. Tamam. Then, what are the classification of the complement deficiencies? You have inherited deficiencies, C3 late deficiencies, and then complement receptor problems and acquired problem. Inherited deficiency, we said that most of them they are autosomal recessive. C1 inhibitor is dominant autosomal. Property deficiency is X-link. These are the pathways. We say why early pathways deficiencies are not common, because you have late alternative pathways. We discussed the C1q deficiencies. We discussed the SLE, presentation of the SLE, C2 deficiencies, MB-lectin pathway, factor B, P and D pathways, propertin pathways, late acting component pathways deficiencies, C3 deficiencies. Then we discussed the protein C1 inhibitor, factor H and deca-accelerating factor and CD59, and we discussed PNH in detail, receptor deficiencies, and then these are the acquired, where we say that acquired may be because of the liver problem, because of the kidney problem, or because of the increased consumption. C1 inhibitor we discussed in the lab, PNH we discussed today, pigagene, GPI protein, and then DAF. Tamam? Thank you very much.